All right. Precision Opinions Live. And today I am actually with Dr. Neel Metha. How are you doing today, Dr. Metha?
I'm doing well, Christian. Thank you so much for having me. This is really exciting to work with you, and I'm sure we're going to discuss why we have such a great working relationship. But
Oh, exactly.
thank you again.
Yeah, no, thank you for coming on. Strange times. We're doing this over Zoom, and last time we got to meet each other, we were doing some events, and we were out in the public, communicating, talking with everyone. So I just wanted to do a quick bio. I know that you were Tufts University, right? Correct.
So yeah, Tufts University up in Boston, Mass. I've gotten rid of my Boston accent, although some people say it comes through.
But you're still a Patriots fan, though.
I'm still a Patriots fan. Even when Brady left, I stayed. But I went to Tufts undergrad, Tufts Medical School, and did my first part of my residency there, and then moved to New York, and have been there ever since.
Okay, and that's what brought you to you're actually the medical director of pain management at Weill Cornell, correct?
That's right. Yeah, I have been on staff since 2010, and in 2012 I took over to be the director, and I feel like I've been there 50 years, but it's been a fun road, and we've learned a lot as we've gone along, and that's, I think, partly what has led to our relationship in terms of how we help patients together.
Oh yeah, of course. Now, before we get into that, our relationship and how we uniquely help patients, discuss your path of medicine. So why you chose the pain field.
Sure.
It seems like you're very passionate. Every time I speak to you about pain, you're just very passionate. So why pain?
It's really quite simple. I mean, I was an anesthesiologist. I loved being in the operating room, helping patients get through surgery. But there was a couple key things that I did not resonate with. And that one was I never really saw any of these people again. And part of medical school was the draw to medicine was to have relationships with patients, to feel like you get to know them and they get to know you. And then the second thing was you may or may not be remembered by them. And so you just feel like the connection wasn't there. Now, that said, there are plenty of people who are great anesthesiologists that are able to get to know people very quickly, put their mind at ease, have them safely through surgery, and they're very thankful and appreciative of that. But I like the longer term connections, and I have felt that pain management allows that. And then the second reason I loved it was part of anesthesiology is you're able to do obstetric anesthesia, where you place epidurals for women in labor, you get them through C-sections. So you come in, you have this woman that's really excited, but also in a lot of pain. And you do a procedure like an epidural, and really, honestly, 5 minutes later, they're a new person. And I've had 3 boys. So my wife has gone through this 3 times, and the person before and after the epidural is a totally different person.
So you can relate.
And so I can relate. So it's a pretty cool experience, but you get woken up all times of the night. And again, same thing. People get to know you. You put them at ease. You do the procedure, and then you sort of disappear. It's like flying a plane. You land the plane, you don't really see that pilot ever again, maybe if you're lucky in your lifetime. Whereas in pain management, think about all the folks that you interact with as on the pharmacy end, and we do that just as much. And they get to know you, and they've seen me grow up and start out as a new doctor. They've seen me now 10 years in. They've met all my colleagues. They've seen the people I train. It's really one big family. And some people come, some people go, but I have a number of patients that I see on a regular basis.
Oh yeah, of course. So that gets to pretty much the topic that can bring us to the main topic of this discussion. One of the main topics is low dose naltrexone, and I know you have patients on that long term for pain and other conditions. So, can you explain low dose naltrexone, kind of how it works, what it is exactly for all the viewers?
Sure. I try to keep this as high level as possible, and if you want to know the deeper science, there's a lot of stuff out there on the web. In fact, I have some podcasts on naltrexone itself. But think of it as a drug that is stimulating your body's natural way to help pain. So people are familiar with endorphins. Endorphins are your positive pain relievers in your own body. We get pleasure, we get relief, we get a lot of positive things that come from that. But in chronic pain, many times those things get dampened down. And so, if there was a way to stimulate production and stimulate release of endorphins, you could counteract the challenges of chronic pain in a very safe way. So, the drug itself works on pain receptors in your body. And if you only use the term naltrexone, you will find things that are completely unrelated. It's used to treat gambling addiction, even potentially alcohol addiction. And that often, if a patient is coming to me with some background knowledge, they may be confused about that part. We're doing it a completely different way. If we take a fraction of the dose, we block that pleasure receptor temporarily. So naltrexone is a blocker of the pain receptor. Hence, if you use it at its full strength, it can help with addiction. But if you do it in low dose, you temporarily block it, enough for, say, 6 to 8 hours. And then the body sort of says, well, hey, this just happened. This blockage just happened. We need to counteract by stimulating our production of endorphins. And so they do that. The body will then start to ramp up the endorphins to counteract this blockage, but then the blockage is gone. And so now you have sort of a increased, or I don't even want to say oversupply, but you have more than you would probably need of endorphin. And that's what leads to pain relief. But also, the endorphins have a lot of other positive things that go along with it. And that includes, it gives you energy, it can improve mood. So when people start to study the relief of low dose naltrexone, they look at and they say, well, yeah, patients talk about the fact that they're feeling better from pain. But if we ask them more detail oriented questions, they will say, I have a surge of energy and I'm tired of being tired all the time. And so the energy is actually a better thing in my life than even the pain relief. Or I have better mood, or I can walk further, or I can sleep better. So all these things that come along with just a simple concept of pain relief.
Yeah.
That's the high level stuff. Then there's some minor discussion of, it has some anti-inflammatory effects. It has some, it blocks some of the responses that happen in chronic pain called interleukin surges and glial cells, all these terms that are involved in chronic pain and the sort of the nature of why things don't get better. And so this really does counteract that. And even why it goes beyond just treating pain. It can treat so many other autoimmune diseases like Crohn's, like multiple sclerosis, like neuropathies from HIV that I don't necessarily treat. But that's why there's so much out there in terms of what it can do. Anyways, Christian, that's me rambling on a long answer.
Well, yeah. So, I mean, it's used for, I would say, 50 different conditions. But that, the way you put it, simple: inflammation and endorphins. Two simple mechanisms. I know that the chirality changes of the molecule makes it work all different ways, but long story short, two different indications. I love that. So I know that Dr. Bahari originally did some of the research at 3 milligrams, and he kind of went down from 50 slowly, I believe.
Mm-hmm.
What are your beliefs on because there's a lot of different people out there using low dose naltrexone, different doses. What are your beliefs on dosing? Where do you think you should start? How do you usually titrate?
Great question. And the short answer is we don't know. So there were studies done going stepwise down from 50. A lot of folks kind of settled on this 3 milligram dose. There was a study out of Stanford that looked at potentially going to 4.5 milligrams. I've even seen some people go a little bit higher, up to 6 milligrams. There was a use of this drug in combating, helping weight loss at 8 milligrams and combining it with a drug called Wellbutrin. Uh, and then there's this concept of ultra low dosing where there's 0.1 milligrams or 0.2 milligrams or so. And then you add the other kicker of, do you use it at night? Do you use it in the morning? Do you take it twice a day, 3 times a day, 4 times a day? The truth is we don't know. And what I do is I basically have to start everybody at something. And I need to have a systematic way. And then I have to figure out along the way, did they get relief or did they get side effects? And if the answer is that they're doing well, we stick with that dose. And if they don't, then we think about changing and going ultra low dose, like starting at 0.1 milligrams. You may ask, like, why don't we just start everyone at 0.1 milligrams and just work our way up? Well, people who suffer from medical conditions like pain, they don't have all the patience in the world. They've been suffering. So if it's going to take 3 months to figure out the right dose, they kind of want to go faster or they give up. So it's a reasonable way to see where I think the majority of our patients benefit. But you probably have a lot of data on what's being used out there, and you probably know the wide variety of doses and frequencies and how people are taking it. And that's why I think it's so fascinating about working with you.
Yeah. So I mean, when it comes to dosing, we work with a lot of physicians, so we see all of their styles for writing low dose naltrexone. Very commonly, people start at 1.5 and then they'll slowly go to 3 and then they'll go to 4.5. What we do to make it simple for some physicians, based on some of the studies and the research out there, is we do a blister pack that contains zero point 0.5, then it contains 1, then it contains 3, then it contains 4. So it's a week of each, so the patient could pretty much pop out each specific strength, so they're not confused and they don't have to have multiple prescriptions. There's just one prescription for the whole titration. And we do offer tablets, capsules. It comes down to what the patient's preference is as far as the fillers. I know there's a lot of research out there regarding the fillers. A lot of patients taking low dose naltrexone have sensitivities. So we could either go with a tablet, which is very affordable, or we could go with a capsule that we have other fillers involved. We have olive oil we could do for mast cell disorders. We could do acidophilus. We could do vitamin C, ginger. So whatever that patient needs or whatever they use as a supplement, instead of using a filler that they might interact with like lactose, we can add a different supplement or something else that will do better for them. And now there's been some new research with using a sublingual under the tongue for malabsorption. So we've been doing that, and we could slowly titrate them up based on them cutting a lozenge in half. So that's where we do offer lozenges as well. But it's been, and then some patients want a suspension. So they just don't react, and we've dealt with patients that haven't reacted to oral tablets, capsules, so we give them a suspension, and then we see creams as well. But there's a lot.
Creams, interesting. I have not seen that.
Creams, the absorption isn't there, obviously, so you do have to ramp it up. But 4.5 per ml in a topical formulation. They apply it once a day. You could see some results, and they are using that for psoriasis as well too.
Wow. Well, look at this. We're discovering things together on our live
There you
feed.
go. This is what it's all
You
about.
know, because one of the things I also do for a lot of patients with muscle pain, neuropathic pain, is we do ketamine and lidocaine together, and sometimes adding other things.
Yes.
I never even thought about LDN in a topical form, and I'd be curious to see if that helps in the muscle related or
Yeah, look at
myofascial
that.
causes.
Now we're figuring things out together.
Yeah, yeah, yeah,
But
exactly.
yeah, explain that if you could, if you don't mind, using ketamine topically, or lidocaine topically. How would you say that works for a patient, and where do you usually use that, and what aspect?
Yeah, great question. So, people are familiar with lidocaine patches, also called lidoderm. Those are 5% strength. Um, it's been useful for patients with shingles, and they have the attack of the chickenpox virus, and they get this nasty, painful rash. Or even if the rash lasts and the pain lasts, they use it for that. And then people started using it, what we call off-label, for treatment of other pains like back pain, knee pain, so forth. And so we knew anecdotally that it was working, but there were some folks that said it just wasn't helping enough, or that they had a challenge of putting the patch on and sticker aspect of it. So we started using topical lidocaine. And I really wanted to see how far we can push it. I mean, we used local anesthetics all the time in our nerve blocks and so forth, so we certainly are familiar with that. And I was getting a lot of patients with really simple muscle related issues, and even really complex Ehlers-Danlos syndrome related pain issues. And so we pushed the strength of the lidocaine. And then my good friend and colleague, Dr. Norman Marcus, who's an expert in EDS treatments, taught me about topical ketamine. And he found that when patients are sensitized, when they have a real sensitivity to chronic pain, and their muscles are even just sensitive to touch, ketamine may work very quickly to relieve that pain. And it partly is therapeutic, but it also gives us some diagnostic value about the presence or absence of sensitivity on the muscle itself. So that's why we use it. I use it a lot in acute injuries and in chronic injuries. I've used it in people with nerve conditions and muscle conditions, and we've had good success. As with anything, when you apply it broadly and you have success, you sort of push the envelope and you try it on a number of patients, especially because it's not harmful. And so it doesn't work in everybody, but it certainly is worth a chance to see.
Oh yeah, of course. Yeah, so that it's gaining a lot of popularity right now, the NMDA receptors, and
Hmm.
just blocking that off, and it really does help. We see fantastic results with that specific cream, using lidocaine and ketamine in conjunction. It really is terrific. Now, getting back to the low dose naltrexone, I had a question for you. As far as the limitations go, where are the limitations? How do you see the limitations in your practice? Is it hard for you to prescribe something like this because of the limitations? And can you explain the limitations with low dose naltrexone?
So the answer really is no. There's no significant limitation. Again, probably the biggest thing is just someone being receptive to it. And as I've prescribed more and more, I think my name has gone out there on various patient support groups. So a lot of patients are coming in and specifically asking for it. There's a lot of enthusiasm and excitement about helping pain with this particular drug. Now, that said, are there particular medical reasons not to use it? And I would say the only kind of loose related thing that I discuss with patients is that if they're on opioids. We talked about how it blocks some of these pain receptors. And theoretically, if somebody took high dose pain medicines like Oxycontin or morphine or whatever it may be, and they took a full dose naltrexone, it would trigger withdrawal. And that would not be a pleasant experience for anybody. But if we give low dose naltrexone and the patient's on a lower dose opioid, there's a realistic chance that nothing would happen negatively there. But we sort of counsel patients to say that that might happen. So what do? We start even slower. We consider microgram dosing. We consider maybe the 1.5 milligram dose to start with. Maybe we try to cut down on some of the opioid. And we manage to avoid it. Really, the only times we've seen withdrawal is by accident. If a patient somehow, some way got the prescription sent to their local CVS or a drugstore that is not familiar with it and dispensed it and they took it, then they may say that they got all kinds of side effects.
And
But
they fill
otherwise, it's not.
50 milligrams.
Yeah, yeah, they get the 50 milligrams. And I'll even go one step further to say that we have had some percentage of our patients that are on opioids that have taken naltrexone, the LDN version, and started to see a reversal of their tolerance. So what is tolerance? It's the same dose of pain medication is not as effective over time. And so you may need to take more. So the LDN has been shown that potentially it can reverse some of these things. And so again, you could combine it. And that's really the interesting phenomenon about LDN and how we sort of use it in such a wide way.
And that's what I find so fascinating about you and how you practice. I remember when you spoke at Yale New Haven, and you presented on low dose naltrexone. You were actually the first person I've heard say that they use it in conjunction, and I learned a lot from that. Learning how you could use it as an ultra low dose and start very, very low, and I thought that was terrific.
So I mentioned my colleague Dr. Marcus, who I collaborate with a lot, and he and I have a healthy
And
debate
I have
all
heard
the
that
time.
name several times.
Yeah. So we
I
have
would call him a legend in the LDN world.
Yeah, exactly. He's a great guy. And so we debate all the time about how to start and where to start on LDN. And I mentioned my way is 3 milligrams tablet and then split it, take 1.5 for the first week every night, and then 3 milligrams the second week, 4.5 the third week, 6 milligrams in the final week. And then we usually confer with the patient, see what's next. He does it 100 micrograms, and you start out the first day once you take that. Then 3 days later, you take 2 tablets, one in the morning, one in the evening. And then 3 days later, you take 2 tablets twice a day, and so on and so forth. Like that's how he goes up. So he always says to me that I am making too big of a jump and starting out too high. Now, again, patients don't love taking things 4 times a day. Partly, I am trying to work with patients to give it a chance, especially those that have never heard of it. And I'm trying to quote unquote sell them on it. I need to have some sort of response. And then if I find out that 1 dose wasn't enough and a higher dose was too strong, then we can work our way in between. So that's, again, this is part of it that we don't know. And my desire is that at some point in our lifetimes, we have a great study of thousands of patients to be able to figure out the answer.
Oh yeah, of course. Now, last question, I'm going to let you go. Side effect profile. Sleep is one of the major concerns. Do you see that very often, or is that something you don't see so much? It's in the literature, and you just let patients know about it.
Yeah, so we talked about how patients reported energy and the boost in energy is one of the positive things. And of course, boost of energy at the wrong time of day, like at nighttime, can disturb sleep. And then we even have had some report in the literature that people describe vivid dreams. Um, I counsel patients on it because obviously every medication has a chance of side effects. The two things I talk about the most are the chance of disrupting sleep and potential for nausea if they take it with food. So the way we counteract that is we try it out at night, lasting before they go to bed, because we think that's when endorphins are most likely to be produced. But I've seen plenty of patients where they switch it to the morning when they have sleep issues, and they don't have any less of an effect in terms of the positive aspects of LDN. And then we just say that you should not eat for a bit, usually about 30 minutes afterwards. As far as other side effects, I mean, anything you put in your body has something and a chance of something that's going to happen. I'd say that probably the biggest thing is the two things we just talked about. Maybe some older folks may think that it makes some dizziness, or a couple of people, for reasons I can't explain, have talked about feeling the opposite, which is tired on the drug. But the majority do not report anything significant.
I've heard that before, that a patient actually felt like it was better for her to go to sleep, and she used it to go to sleep. Actually, a couple times, 2 or 3 patients.
Yeah,
Yeah.
it doesn't make sense to me. I mean, I guess you can always theorize something, but when we tell the majority of folks that it's going to boost your energy, and then the one person that falls asleep, I can't get it. But how do you counsel patients when they're getting this?
So usually we're letting them know about the opioid situation, but we are aware that some physicians out there use it with opioids. So we let them know depending on what the style of the physician is. And yeah, so try it at night, because that's when we do think that the endorphin production is. And if they are having the sleep side effects, which we know that could be nightmares, could keep them up at bedtime,
Mhm.
then we'll tell them to actually use it in the morning. We do like to try to get the approval of the physician to let them know that the patient's going to try it in the morning. But as far as side effects, really it comes down to just the nausea and vomiting we see, which is the same case for any type of medication,
Mhm.
and then the
Mhm.
sleep. So we just let them know those two side effects. I have heard, and I don't know if you've heard of this, but very high doses of prednisone could interact. Have you heard of
Mm.
that or no? No.
So we generally don't have patients on those doses.
Yeah.
We do steroid injections. We use Medrol dose packs all the time,
Okay.
but I have not seen that.
Yeah.
Um, the other thing I do talk to patients about is that we have seen some reports in the literature, and a couple of patients personally, that there is some difficulty in managing pain from surgery or trauma with LDN. And so if they're coming up on a surgery, we generally ask them to stop about 3 to 4 days in advance, get through the surgery, get through their pain recovery, and then once things are sort of settled down, to just resume at the usual dose that they were on before that. I don't know if you've come across that.
No, that's a new one for me. But
Yeah.
all right. Well, Doc, thank you so much for coming on. I really appreciate your time and your energy
Thank
and
you.
your
I love it,
passion.
and I look forward to working together. I guess in conclusion, my patients always ask me, and you're the business manager here, but is there any chance of these things ever being covered, or have you seen them being covered through insurance?
No,
No. Yeah.
no. So compounding, and the reason why it's compounding in 2014 for pain medication got a bad name based on compounding pharmacies hitting the insurance companies over the head. And they did this for a very long time. Now, after that happened, 2015, 2016, the insurance companies were completely fed up with compounding pharmacies. They want nothing to do with compounding pharmacies. So, will it be in the future? maybe. I think something like low dose naltrexone, it's very affordable.
Mhm.
I think that we have a chance for something like that. So maybe in a couple of years, but as of now, nothing, nothing. I wish it would make it easier
Yeah,
for the patients, you know?
sure, sure,
Yeah.
sure. Great.
So give
Well,
the viewers your information just so they could check you out,
sure.
your city location.
So I am based out of Manhattan, New York, New York. I work for Weill Cornell, New York Presbyterian Hospital in the Upper East Side. You can certainly reach us through telemedicine as well. Our office phone number is 646-962-7246. You can certainly find us on the web at Weill Cornell Pain Management. And we also work out of the Center for Comprehensive Spine Care. So a lot of the ketamine, lidocaine cream is being applied in spinal conditions, especially muscle pain. So that's another office I work out of. But again, telemedicine opportunities that make life much easier, especially for those that are listening in from far away.
All right. Well, thank you so much for coming on. I appreciate it. All right.
Thank you. Have a good evening.
All right. Hello, this is Christian Stella from Precision Opinions Live. Please subscribe to our YouTube channel and like our social media links. You can reach us by email at compounding@precisionpharmacy.net or our phone number 516-785-4774, extension 2 for compounding. Thank you very much. Thanks for viewing.